Hello and welcome to the Genetics Podcast. I'm your host, Patrick Short. My background is in population genomics and studying the genetic causes of rare disease. I did my PhD at the Sanger Institute in the University of Cambridge and have been in biotech since 2018 when I started Sano Genetics. Sano Genetics helps academic and industry researchers to run large-scale genetic testing programs that speed up their clinical trials, generate data sets for the next big breakthrough, and give participants the best possible experience taking part in research. Each episode of the Genetics Podcast, we bring you insights from the leading minds in genetics and precision medicine, including household names and Nobel Prize winners, as well as early career scientists and biotechs working on the next big breakthrough. Whether you are a scientist, entrepreneur, executive, patient advocate, or simply someone curious about how genetics shapes our world, you're in the right place. Thank you for listening, and let's get started. Welcome, everyone, to the Genetics Podcast. I'm very excited to be here today with Dr. Helen O'Neill, who's an associate professor and molecular geneticist at University College London, the Institute for Women's Health. She's also the founder and CEO of Hertility Health. We're going to talk about her career as an academic researcher, diving into pre-implantation genetic diagnosis and understanding of CRISPR genome editing in the very early stages of fertility, but also her work as an entrepreneur, delivering women's health at scale through fertility. So, Helen, thank you so much for joining me.
Thanks for having me.
I'd love to start with the origin story. You have worked across a few different areas of reproductive health, and I'd love to just hear a little bit of what got you interested in this and planted the seed for you to focus in this area.
Sure. So my background is straight up genetics. My undergrad degree was a 4-year degree in genetics. And I think really what inspired me to do genetics in the first place was the fact that I am an identical twin, and looking at the identical version of you and constantly probably being blamed for the things that she did and thinking, there's no justice in this system, was probably why I was so keen to understand more about genetics, because actually I came from a really medical family, and genetics, as you probably know, is not something that is particularly au fait with clinicians. In fact, it's totally outside of the medical syllabus. So for me, wanting to understand if I'm genetically identical to this person, and yet I feel we're so fundamentally different as people. Yeah. Why don't we know more about that process? So that's really kind of the most early embryonic origins of my interest in genetics come from my embryonic origins.
That's amazing. Something I've always wondered is, what do we actually know about the genetics of identical twinning? My understanding is non-identical, there's a little bit of a genetic background.
Yeah, so if you're not identical, the woman is more prone to hyperovulation. So right. 2-3 eggs coming out at one time, whereas identical is assumed to be a random split of the egg. However, there are cases of people who just have, by whatever reason, maybe a thinner zona pellucida, so it's more prone to splitting. We did do a study looking at embryos that had been fertilized using ICSI, so when the sperm is injected in, and whether they're more prone, because we see now in IVF more cases of identical twinning. So before, people thought with IVF, twinning happened because you put in multiple embryos, whereas these were single embryo transfers that were ending up as either twins or triplets. So we think it's because when the needle goes in to fertilize, that can actually cause more of a, like the oocyte becomes more prone to splitting, or the embryo.
Right, interesting.
Yeah. So after my undergrad degree, I went and I did a master's in prenatal genetics and fetal medicine at University College London. And this really crystallized my interest in like the earliest origins of how we all form. The fetal medicine aspect of it I found fascinating, because there were so many incidences where, you just saw where things went wrong during pregnancy, to the point where I would see children and newborns and just think, how, like, what a miracle that this came out unscathed, when we know how things can go wrong. And the prenatal genetics side of things, just thinking, how is it that every single one of us is formed in this way, and yet we have so little information about it? So that I went on from there to do a PhD in stem cell genetics and developmental biology at the National Institute for Medical Research in London. And there I was looking at sex determination. So what are the genes that influence either a testis or an ovary forming? And then following that, I did a postdoc and then became a lecturer in reproductive and molecular genetics at UCL. So for the last 10 years, I've been lecturing master students and medical students, and running my own research group on all of those things, particularly looking at early embryo formation, and then looking at ways that maybe newer methods of genome editing could be used to improve our understanding, but also potentially improve genetic disorders in embryos.
Before we dive into a very interesting story that I'll tease that you shared with me before we were recording, I'm curious to hear about the technology shift from that time that you started to get interested through to today. What have the big technology shifts been that have enabled us to do things today in this context that weren't maybe possible when you were starting in your career?
Great question. And I think it's so often overlooked what the technology shifts are, because we often assume that technology is the same as it was, and therefore the same problems arise. So bioethicists love to dive into, the fact that we can't do certain things or that these might have errors, without actually understanding that not just one technology, but a whole cluster of technologies have evolved. And so I always talk about co-evolving technologies. And for me, the co-evolution of genome sequencing, our ability to interrogate the genome at much higher resolution, but equally lower cost. Also chemical engineering. So our ability to really use different vectors, be able to change the sizing, where maybe size and capacity was a restriction before, it's no longer the case right now. And then just really bioinformatics as a whole, but also our ability to just look at embryos, look at things on a much higher resolution, that lends to just an exponential growth in terms, or should rather lend to an exponential growth. But unfortunately, I actually think we're still hampered by old logic, which is that, we can't, or we shouldn't, or maybe it would be problematic. And I'm a big advocate for using new technology and really keeping your finger on the pulse of what is the here and now, as opposed to what could be done 10 years ago.
Yeah, absolutely. So I alluded to this interesting story that I want to dive into. So in 2018, there was a very controversial scientist called He Jiankui who announced what I think at the time was considered to be the first gene-edited babies. There was a lot of concern around the ethics underpinning this, but also I think some scientific questions that emerged afterwards. But my understanding was you were there at the conference where this was very controversially announced. I'd love if you could talk a little bit about what that felt like to be in that room, but then also how that conversation has evolved over the last couple of years.
It was more than just being in the room. So I was supposed to give a talk on how we can safely apply a bench to clinical pipeline for human germline genome editing. So the emphasis of my talk was how we can do this safely and ethically. And I felt like he stole my punchline by coming in and just doing it. So as you can imagine, it was such a strange moment, because I remember finishing my talk on the flight to Hong Kong, and funnily enough, I spoke with, the last hour you chat to the person next to you, and he said, what is it that you want? You as a scientist, why are you going? He said, what is it that you as a scientist want to be known for? And I remember at the time saying, I want to be the first person to edit a human embryo that leads to a healthy life form. And I landed and my phone would not stop. Everyone was like, he's done it, somebody's done it. And I remember being, the more I read about it, the angrier I got, because I thought, I've spent all this time doing so much work about how we tread carefully, about how we first need to understand all of the algorithms that are used for guide RNA design, how we first need to figure out what's the best delivery mechanism. Is it pronuclear? Is it cytoplasmic? Could we use some nanoparticles? What's the best timing? Is it, at the zygote stage? Is it when it splits? What's the best endonuclease you should use? And I remember my talk had this table of all the considerations that we would need to take into account before we would ever do this to a human embryo. And he just did it. Not only did he just do it, then transferred the embryos and led to a pregnancy. So it was this whirlwind, obviously a very sleep deprived whirlwind, because it was of the time difference.
Yeah.
And you could barely hear anything in the auditorium for the amount of clicks of cameras just nonstop going off at that time. And it was just a very strange time, because the aftermath of that had huge consequences. The aftermath meant that I had investigative journalists contacting me, and I remember feeling a little bit scared.
Yeah.
A little bit vulnerable, because I thought, this is not something that is, my intentions were not a short term, let's do this really quickly. My intentions were these wholesome, how do we lay the foundation for something? And I was putting all of that in the context of what we currently use. And that's my biggest consideration for any technology is context. Context is critical. What are we already using that people don't necessarily realize? So when I came home from that conference, I remember explaining to people, you come home and you're in this echo chamber, so you think everyone must be talking about it. And I remember explaining to people, well, this researcher has basically edited embryos to ensure that they don't ever get HIV. And what I was amazed by was the difference in reaction.
Right.
Compared to the world that was there. Everyone was like, he did what? Yeah. Like the rage that ensued. But when I came home and I spoke to friends and people who were just, lay people and explained it, their instant reaction was amazing. Can we do that? Right. I mean, why wouldn't we do that for everybody? And it was very enlightening to think, well, actually, this guy's going to go to jail for this, versus actually what do people think in the absence of any, atmosphere or being told or headline that tells them what they should think. Right. So for me, yeah, it emphasized so greatly the role of public discourse and also media. So the media tells people what they should think, right? The media has such a pivotal role in saying, you're either a hero and a pioneer, or you're a rogue and a recluse and, completely out there on your own. And I do think that there was a lot of cultural bias to that. I did wonder, had this been a jolly British boy or a good old Yank, if this narrative would have been quite different as opposed to the wild, wild west of the East.
Yeah.
It rolls off the tongue to say a rogue Chinese scientist.
Yeah.
Nobody ever describes a rogue US scientist. They're given a lot of leeway for right or wrong, right?
Yeah.
So yeah, it was an overnight lesson in so many things, how we accept things, how we don't, but also how things should be done and how they shouldn't.
Yeah, if we fast forward to today, my perception from outside the field was at the time it seemed like there was a very almost like concerted agreement from the field of this clearly crossed the line. We need to do it more the way you described, where there's a lot of diligence that we need to do to make sure that we've covered off the safety aspects of this before we certainly start to go into more speculative benefits like HIV protection, where HIV protection is already relatively widely available. But today we have the technologies continue to shift. There are companies I know that are offering polygenic risk analysis of embryos and those sorts of things. I'm curious whether the window has shifted a little bit on that, and people are discussing or are the fundamental questions still there of actually, we don't know enough about the off-target effects. We don't really know the downstream implications of broad genome editing. I'm curious to get your sense of where things are today, 6 or 7 actually years later now.
Yeah, exactly. And what's strange is we're still describing genome editing as a new technology. And then we have to stop ourselves and go, oh, it's been 10 years since it came out. Yeah. And it's been 100 years by the comparative evolution of it. So in terms of our progress, how quickly it has advanced, how many more species have been sequenced, how many more bacterial species, even looking for different endonucleases, even in terms of like having a full army of different endonucleases with different functions. It's crazy to see how they have evolved in terms of their editing capability, reduction of off-target effects, and yet the arguments stay the same. Everyone talks about immediately off-target, unwanted edits, all of this catalog of complaints without addressing actually what are the off-targets? Like, what is it with base editing? What is it with, any of the more recent, really elegant forms of genome editing? And that's what annoys me, is that we keep the arguments in the past and we forget that actually things are pretty amazing. In terms of how the impact that had on the field of genome editing, it almost paused it. As you can imagine, for me personally, at that time, I remember thinking, I do not want to be involved in this right now. It's not like any ambition would all obviously be put into very, very significant context when somebody's being put in jail. And, you have to think of yourself as well as not wanting to be a target. No matter how, wholesome your goals were, just to better understand, especially given that we know more about almost every other model organism than we do about humans.
Yeah.
And it serves as this amazing opportunity for us to finally understand something critical about early pre-implantation human embryo development. But as soon as you mention trying to do any edits on a human embryo, people immediately assume not just germline editing, but designer babies. Again, going back to the impact that a headline has on overall ideas of a technology, that it would be used for all of these other, elective traits and selection.
Is there where is the nuance there today from your perspective? Are there traits where we could pretty clearly carve out the safety of deploying something like this to treat or cure is well understood, and it's balanced against the benefit that we have? Are there some categories? Because I totally agree with you that they seem like they all get mashed up together. On one end, we can all agree for the most part that there are elective traits that don't make sense, but I'd like to imagine
right, exactly. There's
are...
traits, and then there's mutations, right? Yeah. So traits are dealing with complex, polymorphic events, and then there's mutations where we can categorically say this is a spelling error in the genome, and this could be fixed. So we have just done a study looking at 48,000 embryos, and what we wanted to look at, these weren't just 48,000 embryos, these are 48,000 embryos from patients who had undergone genetic screening of their embryos, not just for aneuploidy, so incorrect chromosomes, but specifically these were patients who knew they were carriers of a genetic condition. So this was what's called PGT-M, pre-implantation genetic testing for a monogenic condition. So you're a carrier, let's say, of cystic fibrosis, and you want to make sure that your embryo doesn't have it, so they test for it. So we looked specifically at those embryos, and the rationale for this was to say, how many patients go through this genetic selection of their embryos to ensure that their child isn't affected by a disorder? How many of them end up actually with a baby? Because the main argument against doing germline genome editing is that we've got that. We can already do genetic testing on embryos and say, if it carries the mutation, discard it. If it doesn't, it can be frozen or transferred. Yeah. And so we wanted to kind of have an argument to say, what is the actual use case? Do we have ground justification in a subsection of patients to say, these are the patients for whom this would really benefit? So the premise was, and it's unpublished yet, so this is the sneak preview. The premise was
press,
hot off the press, exactly. The premise was, what percentage of embryos, when you remove aneuploidy, would have been amenable to rescue? Yeah. And when we say rescue, we mean don't discard them just because they have a mutation. And what we obviously like to make our work very difficult, because we didn't just look at whether they had a mutation. We also looked at the compounding effect of if you're screening for more than one mutation. So sometimes people are screening for 2 or 3. Yep. So if you add on HLA typing, it makes it even worse. So what you see is, as you can imagine, the more mutations you're screening for, the less likely it is you're going to end up with a baby with a baby. But what was really interesting for us was to see that actually there's a difference in your chance of bringing home a baby, cumulative live birth rate, depending on the mutation. So autosomal dominant versus autosomal recessive. So like a BRCA mutation is less likely than a CF mutation. So what it led us to really kind of form this thesis on is, actually, maybe we can't just go into this blind and try it for any condition, but maybe there are a group of conditions that just don't respond well to, or patients that don't respond well to stimulation if they're carrying a mutation. And maybe this would be a starting point for research for us to better understand whether CRISPR and genome editing would be useful for rescuing these certain embryos in these patients who've undergone multiple rounds of IVF and unsuccessfully ended up with, they've ended up with no baby.
Yeah, that makes a lot of sense to me. So there's undoubtedly a subset of patients that even the IVF process is problematic for them, right? And so they're never going to, if you agree that there's a subset of patients there, they're never going to have an opportunity to have a healthy child. And so maybe we start there to say, if they're not responding or it's it's not effective, or I mean, it's a brutal process, right? If there comes a patient choice at some point in this of is there
this is it.
take that's
and
more
this is what annoys me. People do then tend to lean on the fact that well, you could just go through PGTM multiple times with no regard whatsoever for the woman who's undergoing multiple rounds of stimulation. It's almost as if she's a byproduct of the baby that needs to be produced, not a victim to a failing system that actually is going to really affect her. And I think that there's a lot of problems within the IVF industry that neglects to treat a woman as being, a part of that process.
Yeah, is there a based on where we are as a field today, is there still a hiatus on live, or is there still a hiatus on genome editing in live fetuses, or is it starting to happen in some of these pockets that you identified where there is a real use case?
There is almost nothing being done. When you look at how far the field of genome editing has excelled versus its application in germline therapy, it's almost gone nowhere. There's some research and definitely research being done in human embryos across Europe, but really nothing substantial that would lead to any clinical change, especially when you compare, so much in terms of the advancement in somatic cell therapies. Really, we're just not there when it comes to germline.
What do you think will change if any time soon? Do you think this is likely to be a kind of status quo for the field for a while, or is there something that's on the horizon that would change that?
No, I think it's probably going to be the status quo for a little while.
I mean, the norms that you mentioned are very powerful, right? If regulators are uncomfortable with it and scientists are uncomfortable with it for that reason, then there's lots of stuff you can work on, right? There's a whole lot of problems out there.
There's a whole lot of problems. The biggest problem, I guess, is in terms of legislation, right? Legislation is not the same world over. There's different rules for research. There's different rules for clinical practice. In the UK, there is the Human Fertilization and Embryology Authority, which is a governing body that resides over all procurement and storage of gametes and embryos. So they are essentially like the regulator for any IVF clinic and any research that would be done in this field. But there is no such entity in the US. There's no such entity pretty much anywhere else. And it would require almost like global oversight and governance, which is kind of what a lot of the World Health Organization group came out with. But in order to get global oversight and governance on something that is so polarized in terms of, the experts are still at either end of that debate, whether it definitely should be done, whether it definitely shouldn't be done. There doesn't seem to be much of a voice in terms of like, I'm ambivalent. But when you ask the public, actually, that's where it gets really interesting, because when you ask the public a series of questions relating to whether or not they would do this on their own embryos, had they the choice, most will say yes. Yes, I would
really
absolutely screen my embryos to make sure they weren't sick.
Yeah.
Nobody agrees that we should be doing it to make sure that they're higher right to intelligence, although people probably more aesthetic traits people are less likely to agree to. But actually, that's again what was interesting about me coming back and saying about He Jiankui to friends and seeing their reaction versus what we're told to believe. If you look at it from the offset, and this is why I love to compare it to pre-implantation genetic diagnosis, is when you say, okay, what are we going to do to the embryo? Okay, we're gonna probably inject some material. Okay, we do that anyway when we inject the sperm, some DNA, 50% of it from the sperm. We're gonna then have to take a biopsy. Okay, we already do that. There's actually very little, almost no difference in terms of how you treat an embryo in one scenario versus the other. The only difference is in one, you're getting a result and you're going to say, I'm going to discard this embryo because it has a mutation. In the other one, you're potentially correcting the mutation and making it amenable to transfer for the patient. So if you were to look at it from a completely new lens, one might argue actually that this is far more ethically sound to correct and rescue embryos than it is to discard hundreds of thousands of embryos in a world where people are desperate to have a child.
Yeah. I think the framing is at least worth discussing, right? And it is it's an area I don't know enough about to really understand the nuance of how the field might shift. But something I was thinking about was the increase in newborn screening. We're starting to see whole genome-based newborn screening pick up steam. And I wouldn't be surprised if this causes us to look at this in a different way as we start to see many more diseases that are picked up in early childhood can't yet be treated, and reopens the conversation of, are there things that we might be able to do upstream for these families to help? And I do agree with the framing you had before, where we have a lot of tools in the toolbox, right? There's family planning approaches, there's IVF and PGTM, but those aren't going to solve for every case, right? And I think if you just apply a common sense framing to it, families want to have healthy kids, and if we start from that framing, then there probably is a lane for this to be impactful and not have all the issues that some of the previous generations of these attempts have had.
Exactly. And I think it's about educating people as to what is currently available. And actually, when you think about things quite sensibly, a lot of people would say, yes, screen my newborns, for sure. Another study we did was to look at the clinical utility of newborn sequencing, and to see, what percentage of cases would have been picked up. And again, there's a huge opportunity in sequencing of newborns to prevent or at least address conditions that don't get found out for a long time. And I always think of, phenylketonuria. Now it's built in, and it's such a no-brainer. It's built in PKU screening because of this one intervention that we can make. A simple avoidance of anything with phenylalanine means the child does not become mentally retarded. That's easy. That's so easy. And it's in our newborn screening. But how many other PKU-like disorders are there that we just don't know about or we don't screen for? There are 700 inborn errors of metabolism, and we screen on average for 9, 10, 25 in certain countries. That's it. 700 that could be readily screened for and have actionable changes in these children, let alone doing, pharmacogenomic testing on kids to say, well, there's a lot of unnecessary prescribing that shouldn't happen. Maybe this could save a life if we did this early on. But investment into healthcare is unfortunately not resourcefully allocated. And they tend to invest in getting us to Mars.
On another topic of maybe suboptimal investment into healthcare, you've spent a good chunk of your time as well as an entrepreneur focused on your company, Hertility, which is using at-home health to address some of the major fertility challenges that women face and are traditionally underserved by healthcare systems. I'd love if you could talk a little bit about what inspired you to do that work there and a little bit about the company.
Sure. So I started Hertility about 6 years ago, and it really was born out of frustration to one extent, but also just seeing that there is, when I worked so closely with IVF clinics doing research and lectured masters and medical students about fertility, more specifically about age-related fertility decline and infertility, it's hard not to be affected by that personally and think, well, God, I'm a woman in my 30s and maybe am I the exception or am I the rule? Either way, I would like to know. And to think that I remember saying, I have all of these contacts, these, world leading experts in fertility in every aspect of women's health. And there was no kind of in-between way of me finding out about my own fertility and wondering from a personal lens, am I the statistic, right? Am I just going to fall within the statistic? And from a genetic perspective, I remember thinking, well, we would always take into account lots of different factors rather than assuming one thing. Yeah. And so I really didn't think that I knew nothing existed outside of going to a fertility clinic where you're all of a sudden on the journey to go through fertility treatment, right? And I just wanted to know. I was like, how can I just find out? Am I okay? Do I have time to wait? Or do I do like all of my colleagues are telling me to do, freeze my eggs?
Yeah.
And just wanting to have a little bit more data on making that decision. It's a big investment. And also being on an academic salary, not being able to afford that investment, and thinking, can I I don't know, figure this out? And
I solve my own problem. Yeah.
yeah, exactly. So I applied for a grant to develop predictive algorithms for gynecological pathologies and fertility, to say, actually, if we take into account all of the different pathologies that you might face, all of the different structural or hormonal things that might cause you to be infertile, maybe we can work out what your fertility is. And so that was a very optimistic grant application that I got, and it would allowed me 3 years to essentially build predictive algorithms. But that was a clinical trial that was due to recruit women with a known pathology in clinic. And then we were going to take all of their medical history, bloods, and work out, could we have predicted this pathology? Are there overlapping features in all of these patients who have this pathology that we can predict then in the general population as a screening tool? And that was when lockdown hit. So it meant that just as we were set to recruit, all clinics that were deemed non-essential were shut down. So it says a lot about how we view women's health that all of those clinics were shut down. I mean, we're still suffering the wait list in the UK. There's nearly 700,000 women on a wait list just to see a gynecologist because of that delay and deprioritization of women's health and access to specialist care. So in a strange way, that worked in our favor, because we put together a really basic website and asked women, are you interested in learning about your fertility? And we had 7,000 women register their interest. So it was this catalyst that said, this is not just me who lives in an echo chamber, who hears about this every day, that is therefore worried at night. This is a lot of other women who are seeking this answer and not wanting to step foot in a fertility clinic, which is extortionate, and being dismissed from or sent away from their general practitioner because there's actually criteria that you have to go past in order to be referred. Like, you have to have had miscarriages, you have to be trying, you have to have, you know, all of these things. What if you were just curious? So that was a really amazing moment to say, we've got to do this, we've got to build this. And so today we have the largest data set of its kind. We have over 620,000 women who have done that full health assessment, and we've developed predictive algorithms for how well we can determine these gynecological pathologies. So we can, with 98 to 99% confidence, both precision and recall, detect 18 different gynecological conditions within 8 days. So it's a really amazing place to be right now, especially when building that first version of the health assessment. I remember going back to the textbooks being like, right, let's include all of the diagnostic criteria and guidelines. Let's make sure we miss nothing. But looking at all of the seminal papers from which these guidelines were set and thinking, this is outrageous that it's on 30 women or a maximum of 100. You're like, the global guideline for this is so poor, like poorly set, that we can do better. So yeah, it's been an amazing journey to be able to use real world data from real women, today's women, not textbook women, whereby actually vaping didn't exist. And now we can see vaping has a systematic reduction in your fertility.
Wow. I was going to ask, what else have you learned?
Even if you're an occasional vapor, it systematically reduces your fertility hormones. You know, that's something that we don't, or even like drug use. You don't get data on some of these really obvious factors of somebody's life that are definitely going to impact them in a routine face-to-face clinical appointment, because it relies on the clinician to ask that question. It relies on the patient to answer it honestly. And it relies on, you know, somebody documenting that. And we see with a digital interface that asks so many questions, there's no judgment. There's no, there's an ability for us to educate as to why we're asking that question.
There's also something remarkable about going from the textbook recommendation to the personalized recommendation. So about, like, everyone knows that drinking alcohol messes with your sleep, right? No one is surprised if you say, if you have 3 or 4 drinks, it will mess with your sleep. But I started wearing this Whoop 3 years ago, and I saw with my own eyes when I had a drink what it did to my resting heart rate as I was sleeping, and I stopped drinking because I was like, I don't really, doesn't change my experience if I go out and have 2 beers instead of 0, but I can actually see on the watch, like it really messes with my sleep. And I've got to imagine you've got the same effect where you can say all you want, alcohol or vaping affects your fertility, but if somebody sees it in their results, it's a different conversation, right? It's personal.
Exactly. It becomes, it's weird. Nobody likes to be lectured, even if it's the most obvious thing. Don't eat this, do eat that, right? People resent just generic advice.
Yeah.
But when you see the impact, direct impact on you, then it's like, okay, this is a cause and effect that actually affects me.
Yeah.
And that is quite powerful.
I know you don't have genetics in the product yet. You've got a battery of different hormones that you look at. Would there be something that you could tell people based on polygenic risk scores or something else if the price point or customer interest got to the point? I don't know much about how much genetics is driving some of these in addition to the things you can observe through the hormones.
Yeah. So when we started, I'm really fortunate in that I was director of a master's program in reproductive science and women's health. So I had my selection of MSc students who did their research projects with me. And I probably ruined all of their careers by telling them, let's do a systematic review and meta-analysis on all of the genes associated with these different conditions. Because my goal was, if we can create an array or a panel of genes that we could test these women, then we could say with high confidence whether they have these pathologies. And what came back from all of these systematic reviews are, number one, they're always flawed the way they're done. But number two, there's not just 1 or 2 or 20, there's thousands of genes that seem to have roles, whether it's in the mitochondria, whether it's in different aspects. And it was so, in ways, disheartening. And in other ways, I just thought, actually, it's hard to educate women around their health in general. And when you add something as complex as genetics, having to explain that to them, especially when it's not actionable, is not really adding value to that person. I obviously have a huge passion for genetics, and I think that there's a role in implementing genetics going forward. We're setting up a biobank at the moment whereby we'll be able to do lots of different omic studies, including genomics. And that, to me, is where we can build multimodal AI data sets that inform clear and accurate diagnosis for individuals, but also where we'll start to see changes over time and really just build on a longitudinal data set for women, because it just doesn't exist.
Yeah, I think that's a brilliant idea, because you could probably add a ton to the understanding of biology around how people respond to different treatments that they might be on, how each of the hormone levels that you measure are influenced especially with people doing tests over time. So yeah. I think that makes a lot of sense. And the consumer facing part can come much later once you figure out how to distill that into a crystal clear message, right? Versus you throw a polygenic risk score at somebody and they don't know what to do with it because it's, it's not, like you said, it's not yet actionable.
Yeah, exactly. Yeah.
Amazing. Well, as we wrap up here, what are the big things that are on the horizon for you? What are you working on today that you're most excited about?
From a fertility perspective, I'm so excited about building this biobank, but also how we're able to use this cluster of data points to accurately diagnose and screen for these different conditions. To me, is where big data really plays its role. It annoys me that big data has become a dirty word almost. And that's because of how it's used in terms of advertising and all of these other ways. But health data is so valuable at scale to make such actionable differences to people, that is where the future of healthcare lies. In terms of my own academic work, I'm most excited about being able to really just fully understand just the use case for germline genome editing. For me, I think that it is an unfinished chapter. I think that there is much more conversation to be had. And when we looked at how legislation changed for mitochondrial replacement therapy, not because scientists were lobbying, not because politicians were lobbying, but because patients were lobbying for this change. And I think if we can really get on the side of patients and give them a voice, especially people with, a lot that are carrying different mutations or conditions within their family line, I think maybe we can come at it from a different standpoint.
Amazing. Well, this was a super discussion. Thank you for sharing all the experience and insights, and look forward to speaking again soon.
Thanks. It was great to chat.
Thanks everyone as always for listening, and we'll see you next time.
That wraps up this week's episode of the Genetics Podcast. I'd like to give a huge thank you to our guests for sharing their valuable insights and experience. And thank you as well to our listeners, as always, for tuning in. If you enjoyed today's talk, the number one thing I would really appreciate from you is if you could share it with a friend or colleague who you think would enjoy it as well. We would also really appreciate if you could subscribe to our show and give us a quick rate and review on Apple Podcasts, Spotify, or your favorite podcast platform. Both of these things help us become more visible when people search for genetics and precision medicine podcasts. And we're always eager to hear from you. Please reach out to us with any questions or feedback on social media. You can find Sano Genetics on Twitter, LinkedIn, or visit sanogenetics.com. Finally, a big thank you to the team behind the scenes who make all this possible, in particular Amy Cousins and Sonia Shah who produced the show, and James Pierce from Selected Frequencies who handles the audio engineering. I'm Patrick Short, your host, and it's been a pleasure. Thank you, and we'll see you next time on the Genetics Podcast.